Today's topic for the lecture is stomach and duodenum, the common conditions that affect the stomach and the duodenum. In part 1 of the lecture, I shall be dealing with the anatomy, physiology, regulation of acid secretion, and the investigations of stomach and duodenal conditions. First, the anatomy of the stomach. The stomach is a pear-shaped organ, as you can see from this diagram here. It's a pear-shaped organ with the upper and lower end fixed. Okay, this is the upper end, which is fixed, and this also the lower end, which is fixed to the posterior abdominal wall. This is at the hiatus of the diaphragm, and here is the pyloric end. The middle portion is mobile. Okay, that is very important. Two orifices, okay, the cardiac orifice and the pyloric orifices. These are the two orifices. This is the entry of the food, and this is the exit of the food. Two surfaces, the anterior, this is the anterior surface, and if you flip the stomach over, you can see the posterior surface. There are two curvatures, the lesser curvature and the greater curvature of the stomach. And the stomach is divided into a number of parts. Okay, the fundus, the cardia, the body, the antrum, pylorus, and the spiloric, with the spiloric sphincter here, which acts as a valve, and also this angle here, angulation here, known as the incisura angularis. Okay, these are the main parts of the body, the stomach. Okay, next we come to the arteries or blood supply of the stomach. Okay, these are the 5 arteries that I've listed, and which is indicated in the diagram here. The first is your left gastric artery. Okay, left gastric artery, which originates from the celiac artery, or celiac trunk, or celiac axis as it is called. The second one is your right gastric artery. The right gastric artery originates from your hepatic artery. Then you have a few short gastric arteries supplying the upper part of the stomach and the fundus. Okay. Then you have got your fourth one is your left gastroepiploid artery. This one from the splenic artery. Let's come here. And then this anastomoses with your right gastroepiploid artery, which is a branch of your gastroduodenal artery. This gastroduodenal artery is an important artery because in cases of bleeding ulcer, the source of bleeding is this artery. The ulcer erodes posteriorly into this artery. So in general, these are the 5 main arteries that supply the stomach. And it's important to note they all finally originate from the celiac axis. That is the abdominal aorta. Next, we look into the veins draining the stomach. All the veins that drain the stomach finally empty into the portal vein, is shaded blue in color here. On the left side, the left and right gastric veins, okay, this is the left gastric vein, this is the right gastric vein, which drain the stomach along its lesser curvature, drain directly into the portal vein. The short gastric and the left gastroepiploid veins, here, the short gastric and the left gastroepiploid vein they drain into the splenic vein. Okay, which continues to join the superior mesenteric vein to form the portal vein. The right gastroepiploid joins the superior mesenteric vein. Okay, the right gastroepiploid joins the superior mesenteric vein directly. Next, we come to the nerve supply of the stomach. Okay, the nerve supply comes from the parasympathetic and the sympathetic supply. The parasympathetic, which is the dominant supply, is the main extrinsic supply of the stomach. It mainly comes from the vagus, which is the cranial nerve 10, which forms vagal plexuses around the esophagus. And as it reaches the lower end of the esophagus, this plexus forms bundles. They're known as the left vagus and the right vagus. And as it enters the abdomen, the left vagus becomes the anterior vagus, okay, because it is seen on the anterior surface of the lower end of the esophagus and anterior surface of the stomach. Okay, this is the anterior vagus. The right vagus, bundle of vagus, as it enters the abdomen, becomes the posterior vagus, which goes behind the lower part of the esophagus and stomach. Okay, so basically sympathetic, parasympathetic is your anterior vagus and posterior vagus. And the sympathetic supply is derived mainly from the celiac ganglia, the ganglia around the celiac axis, the celiac artery. Okay, now we come to the lymphatic drainage of the stomach, which is very important topic for cancer of the stomach. Okay, the stomach is divided into 4 zones, 1, 2, 3 and 4 as shown in this diagram. From the antrum, that is around this region, okay, from the antrum, the lymphatics drain into the right gastric, here, right gastric, right gastroepiploid, this one here, and also your subpyloric lymph nodes here. Okay, so basically the antrum drains into the right gastric, right gastroepiploid and subpyloric lymph nodes. And efferent from the suprapyloric lymph nodes will then converge to the celiac axis and the parietic nodes here. Efferent from the subpyloric lymph nodes pass up the main superior mesenteric lymph nodes and into the area surrounding the superior mesenteric artery. So this one is the celiac axis, this is the superior mesenteric artery. And from the cardia of the stomach, the lymphatics communicate freely with those of the esophagus. Okay, this is the paracardial lymph nodes here. The Japanese surgeons have divided the lymph nodes of the stomach into groups for the purpose of surgical resection in stomach cancer. The N1 lymph nodes are the lymph nodes adjacent to the stomach. Okay, they lie on the surface of the stomach adjacent. The N2 lymph nodes are nodes along the named vessels such as the right gastric, left gastric, epiploid, right and left epiploid. These are all the N2 lymph nodes. And the N3 lymph nodes are those which lie further away from these named vessels. So they divided into 3 tiers. N1, N2, N3. Now we come to the short few words about this anatomy of the stomach. The stomach consists of 4 layers. The innermost layer is the mucosa, okay, followed by the submucosa, mucosa, submucosa, and then followed by the muscular layer, which is in 3 layers. The innermost is the oblique muscle, followed by the circular muscle, and then the outermost is the longitudinal muscle. You can see here circular and longitudinal. The circular muscles are important because at the pylorus and at the cardia they form sphincters controlling the entry of food into the stomach and exit of food again from the stomach. Then outermost layer is known as the serosa. It's also important to realize the stomach has got its own intrinsic nerve supply through the myenteric plexus of Ioba and the submucosal plexus of Meista. Okay, so these are the intrinsic nerve supply of the stomach. Okay, the next important part, the anatomy, is the cells in the stomach. This is very important. The stomach has got numerous glands known as the gastric glands, and these are known as the crypts, which enter into the glands. And these crypts at the surface are guarded or openings known as gastric pits, which lead into the crypts. Okay, and these crypts or glands are lined by mucosal cells of different types of mucosal cells as shown in this diagram here. Okay, you have the parietal cell, which is responsible for the production of hydrochloric acid. Chief cells, which is the bulk of the cells, is the chief cells, which produce the digestive enzymes, pepsinogen, and scattered among them, especially in the deeper part of the pits, will be the endocrine glands. Okay, enteroendocrine glands. Okay, which secrete hormones. Okay, three types. You have the parietal cell, chief cells, and endocrine cells. The cells in the stomach. The first group of cells are the parietal cells, which produce hydrochloric acid. The hydrogen ions are actively secreted by the proton pump, which is a hydrogen potassium ATPase mechanism, which exchanges intraluminal potassium for hydrogen ions. Potassium from the lumen passively move into the parietal cells, but hydrogen ions are pumped against an immense concentration gradient. The next group of cells in the stomach are the chief cells. Chief cells produce pepsinogen. These cells lie proximally in the gastric crypts and they produce pepsinogen, which is the inactive form of pepsin. There are two forms that are produced, Pepsinogen1 and Pepsinogen2. Pepsinogen1 is only produced in the stomach. Pepsinogen is activated in the stomach to produce digestive protease called pepsin, which is the active form of the enzyme. So pepsinogen activated in the stomach by acidic pH with the presence of hydrochloric acid to active pepsin. The chart here shows you the activation of pepsinogen is two stages. First is the activation by hydrogen ions. Hydrogen ions in the hydrochloric acid activate the pepsinogen to activated pepsinogen. And this undergoes another chemical reaction where the 44 AA polypeptide is removed, cleaved from the pepsinogen, and then results in active pepsin. The third group of cells are known as the endocrine cells, which produce the hormones gastrin, histamine, and somatostatin. The G cells in the mucosa of the gastric antrum produce gastrin. The enterochromaffin-like cells, or the ECL cells, which is abundant in the body of the stomach, produce histamine, which is important in stimulating the gastric acid secretion. T cells are numerous throughout the stomach and they produce somatostatin. Somatostatin has a negative regulatory role. In summary, the endocrine cells, G cells, the antrum of the stomach, stimulate gastrin, which increases hydrochloric acid. ECL in the cells in the body of the stomach also increase histamine, which also increases the release of hydrochloric acid. D cells, which is found throughout the stomach, produces somatostatin, which inhibits the production of hydrochloric acid. Now we come to the duodenum. This is a picture of the duodenum, how the mucosa looks like on endoscopy. Okay, it's a C-shaped organ. Okay, you can see here the stomach comes over here, continues as pylorus, and then becomes the duodenum. First part of the duodenum, second part of the duodenum, third part of the duodenum, and fourth part of the duodenum as indicated here. There are 4 parts. Okay, this is the first part, second part, third part is the transverse part, and then this one is the ascending or your fourth part of your duodenum. And most parts of the duodenum are retroperitoneal. And the common bile duct and pancreatic ducts join the duodenum at the second part, okay, at the ampulla of water. Okay, this is a picture of the histological picture of the duodenum, which consists of the villus, numerous villi to increase the surface area for digestion. Then is the muscularis mucosa, submucosa, and the muscular layer. Okay, and the cells that contain in this duodenum are goblet cells, which secrete mucus, Brunner's glands, which secrete alkaline bicarbonate in the submucosa that are similar to the pyloric glands of the stomach. Then they also got endocrine cells, the duodenum. They produce cholecystokinin, CCK, and secretin. Okay, and also the important thing, I told you just now, gastroduodenal artery lies posterior wall, runs in the posterior wall of the first part of the duodenum, and that is an important vessel because posterior ulcers can complicate by eroding into this vessel and causing severe upper GI bleeding. Next we come to physiology of the stomach and duodenum. Okay, this is another important topic which is involved in the production of hydrochloric acid and the regulation of hydrochloric acid. Okay, the stomach, as you all know, is the most dilated portion of the alimentary canal. It has got 3 main functions. First, storage of food, act as a reservoir for ingested food. The adult stomach capacity is around 1.5 liters. Second, mechanically mixes food with the gastric secretions, and this forms the semi-fluid status of the food, and that is known as chyme. Okay, it produces chyme, converts the food into chyme. And the third function is it controls the rate of emptying of this chyme into the intestine for efficient digestion and absorption. You cannot empty all the contents of the stomach into the intestine because then it will not be digested well. So it controls, releases little bit at a time so the duodenum can digest the food efficiently. The duodenum, on the other hand, has endocrine cells which produce cholecystokinin, which I told you, it stimulates the pancreas to produce trypsin and causes gallbladder contraction. So this is released after when the food is taken. When food is ingested, it stimulates the release of this hormone. The next hormone it produces is an inhibitory hormone known as secretin. Okay, it inhibits the gastric acid secretion and promotes the production of bicarbonate by the pancreas. Okay, so that means the secretin neutralizes the acid that comes from into the duodenum from the stomach. Next, all important phases of gastric acid secretion. Okay, this is a summarized diagram. There are 3 main phases. First of all, the cephalic phase, which is vagus mediated here. Okay, is secondary to sensory arousal, the sight of food, smell of food. This will be by the vagus. The second phase is the gastric phase, or gastric mediated. Okay, and this is the gastrin mediated, not gastric. It's a gastric phase but mediated by gastrin. Okay, so this is the G cells, chemicals and food in the stomach. Then the G cells are stimulated to release gastrin, and this gastrin has a stimulatory effect on the parietal cell, which has plenty of gastrin receptors. So it stimulates the production of acid. The third one is the intestinal phase, which is largely inhibitory. Okay, presence of chyme in the duodenum and small amounts and small bowel inhibits the gastric emptying. Acid in the duodenum leads to production of secretin, which inhibits the gastric secretion and increases production of bicarbonates, so it makes the duodenal environment more alkaline. Okay, the parietal cell has got the G receptors for gastrin, the H receptors for histamine, and the M receptors for the muscarinic receptor. Okay, so these are stimulated by acetylcholine, which is released by the vagus nerve endings, and release of acetylcholine due to distension of the stomach, and this will stimulate the M receptors. Then the gastric cells, the ECL cell, the endocrine cells release histamine, which also stimulate the parietal cell through the receptors known as the histamine receptors in the parietal cells. So important to note, the vagus nerve has a regulatory effect on all the mechanisms of acid production. So it's a very important, that means the vagus nerve is a very important source of stimulus to the production of acid. Gastric acid secretion. Gastric acid is, as I said, there are a number of numerous factors that are involved: neurotransmitters, neuropeptides, peptic hormones, and so many factors are involved in the regulation of acid secretion. The vagus nerves release acetylcholine. Okay, we stimulate the acetylcholine receptors on the parietal cell. Acetylcholine and gastrin stimulate the ECL cells of the stomach to release histamine, and this histamine also stimulates the parietal cells through the histamine receptors. And this histamine acts in a paracrine or local fashion on the parietal cells via the H2 receptors. Okay, so now we know what are where the H2 receptors are located, and the use of H2 receptors antagonists will reduce the acid production. Acetylcholine can also directly stimulate the parietal cell through the vagus. Food in the stomach can cause G cells to release gastrin, which I told you in the last slide. And the acid inhibit the production of gastrin, and this acts as a negative feedback loop. Okay, increase gastrin, increase acid, and increased acid will produce increased negative feedback on the gastrin, thereby it self controls or regulates the production of acid. Within the parietal cell, this is a ATPase system. It's the proton pump. Okay, that is the potassium, hydrogen ATPase system. Okay, this is the blood. This is the lumen of the intestine. The chloride ions are taken out from the blood and they go into the lumen, and this chloride combines with the hydrogen released from the proton pump to form hydrochloric acid in the gastric lumen. And this source of proton is from carbonic acid, which is produced from water and carbon dioxide in the presence of the enzyme carbonic anhydrase. This releases carbonic acid, which again is split into bicarbonate and hydrogen ions. The hydrogen ion is pumped into the stomach lumen by the ATPase system, proton pump, and then it combines with the chloride there. The bicarbonate that is produced from the carbonic acid diffuses back into the blood, and that is known as the alkaline type. Next we come to the gastric mucosal barrier, which is a very important barrier which protects the gastric mucosa from damage by toxic environment. This is due to the presence of a viscid mucus layer of polysaccharides, mucopolysaccharides, which are produced by the mucus producing cells of the stomach. This gastric mucus layer is an essential physiological barrier to protect the gastric mucosa from mechanical damage from food ingested and toxic effects of acid and pepsin. The buffering capacity of this mucus layer is enhanced by the presence of bicarbonate ions within the mucus. Factors that can cause a breakdown of this gastric mucosal barrier, such as bile, non-steroidal anti-inflammatory drugs, alcohol, trauma, and shock. The high incidence of stress ulceration in patients who are severely ill and in shock due to stress ulceration is because the stomach is the most sensitive to ischemia and also the slowest to recover from the effects of ischemia. Okay, this picture here shows you the gastric mucosal barrier. Okay, with this high concentration of bicarbonate ion that increases the surface pH of the mucus layer. Now we come to the investigations of gastric disorders. Okay, I've listed here 5 important investigations. Okay, the most important of these, I'm sure you all are very familiar, is the flexible endoscopy, or OGDS, esophago-gastroduodenoscopy. Okay, the most commonly used and sensitive investigation of the stomach and duodenum. Okay, it provides you a direct observation and biopsy if necessary. Okay, the invention of this fiber optic endoscopy, or OGDS, has revolutionized the treatment of gastric and duodenal, esophago-gastric and duodenal diseases. Next is computer tomography, or the CT scan, which may be necessary in some patients, especially when you think of tumors and also for the staging of gastric cancer. Third is the endoscopic ultrasound, okay, which is a new development. It's the most sensitive technique for evaluating the T stage of gastric cancer and assessing duodenal tumors and also the tumors, periampullary tumors and pancreatic tumors in the head of the pancreas. Fourth, laparoscopy, very sensitive in detecting peritoneal metastases. Okay, gone are the days where we do exploratory laparotomy to stage the disease and decide on the nature of treatment. These days, we can go directly for laparoscopic staging of the peritoneal detection of diseases. And fifth, the last one is your laparoscopic ultrasound. Okay, through a laparoscope, you can introduce a ultrasound probe which gives you an accurate evaluation of the lymph node and liver metastases, and therefore a more accurate staging of the disease cancer. Okay, this is a slide showing you the flexible endoscopy, and these endoscopic methods can not only diagnosis, is advantageous not only diagnostic, it also has got therapeutic effects. These days, bleeding of ulcer, polyps, and all sorts of tumors, small tumors, can be treated by endoscopy. Previously, we had the fiber optic endoscopy, and now the better camera system, video system, known as under the solid state video camera. The gastroscopy and biopsy channels are also available. Suction, washout, all sorts of channels are available, which makes the scope a very important tool for the surgeon. Here, you also can have endoluminal ultrasound or the endoscopic ultrasound, where you can see the gastric cancers which can be detected at a very early stage and can be staged. Okay. 5 layers of gastric wall may be identified, which I showed you just now, the layers. That's very important to assess the depth of invasion of the carcinoma of the stomach and to detect enlarged lymph nodes, the N1 lymph nodes in the stomach. Okay, this slide is to demonstrate the flexible upper endoscopy, which is commonly, or is more popularly called OGDS, which stands for Esophago-Gastroduodenoscopy. This is done by the patient under heavy sedation as a day case and with the patient lying on the lateral position. Adequate lidocaine spray is applied to the throat and heavy sedation is also given intravenously. The surgeon stands in front with the scope and he slowly guides the scope into the mouth and guides it down into the esophagus. As he gently passes the length of the esophagus, he looks for abnormalities in the color, shape and mobility of the structures, the cardioesophageal juncture, then the parts of the stomach, the fundus, body, antrum and pylorus, and also the first and second part of the duodenum. As an experienced endoscopist, he should be able to be familiar with the various parts of the upper GI that he will be seeing during the endoscopic procedure, from the cardioesophageal junction right until the duodenum and the second part of the duodenum. In part 2, I will go on to discuss some of the diseases of the stomach, mainly acute gastritis and peptic ulcer. Diseases of the stomach. The list of diseases that I mentioned on the left are the common conditions that affect the stomach and the esophagus. GERD, gastroesophageal reflux disease, should be covered in another lecture. Acute and chronic gastritis, which I will cover today. Peptic ulcer and cancer. On this right, the list here are some of the rarer conditions or diseases of the stomach, which will be covered in another lecture. First, we come to gastritis. The first 5 here in blue are the common types of gastritis that we see in our patients. Type A is gastritis is autoimmune disease. Type B, gastritis, is due to Helicobacter Pylori infection. Then you've got reflux gastritis, erosive gastritis, and stress gastritis. Okay, these are the 5 common types of gastritis that we see. The others, number 6, 7, and 8, are seen on and off, but they are really rather rare in our patients. Okay. Type A gastritis is autoimmune condition due to circulating antibodies to the parietal cell in the stomach. As a result, there is atrophy of parietal cell mass leading to hypochlorhydria or achlorhydria, either the decrease or absence of hydrochloric acid in the stomach. The third factor is the intrinsic factor is reduced in these patients because of the atrophy of the stomach. As a result, there may be malabsorption of vitamin B12 resulting in pernicious anemia. Normally, the body of the stomach is more affected. The antrum is not affected and there's no ulceration seen in these cases. The second type of gastritis is due to Helicobacter pylori, which is becoming more and more prevalent and more common and more understood these days. Mostly affects the antrum and is prone to peptic ulcer. The second condition that it predisposes is band gastritis, diffuse gastritis caused by the bacteria. The pen gastritis is most prone to develop gastric cancer. Intestinal metaplasia associated with chronic pen gastritis with atrophy is a common complication. Intestinal metaplasia associated with dysplasia has a significant malignant potential. Okay. The third type is called erosive gastritis, and this is due to the disturbance of the gastric mucosal barrier, and is commonly due to non-steroidal anti-inflammatory drugs. NSAIDs and alcohol are the two common causes. NSAID-induced gastritis is usually associated with inhibition of the cyclooxygenase type 1, COX type 1 receptor enzyme, thus reducing the production of gastric cytoprotective prostaglandins. Specific cyclooxygenase type 2 COX-2 inhibitors reduce the incidence of these side effects. And long-term use of these COX-2 inhibitors are associated with cardiovascular complications, as is common with the use of NSAIDs. Okay, this chart here shows you the mechanism of action. Okay, the inflammatory response is caused by the arachidonic acid, which is the omega-6 that we get in the food, and this causes the general inflammatory reaction. Is mediated by the COX-1 and COX-2. COX-1 is usually beneficial, as the inflammation produced is beneficial to the patient, especially the PGI2, which provides cytoprotection to the gastric mucosa. Whereas COX-2, which is a mediator of acute inflammation, has its harmful long-term effects. Okay, in short term it may be beneficial, but on long term it causes harmful long-term effects. Okay, so the traditional NSAIDs inhibit COX-1 and COX-2. They are inhibitors of COX-1 and COX-2, and as a result, both the protective and harmful effects of inflammation are seen in the patients. Whereas the specific COX-2 selective inhibitors, they only block the harmful part of inflammation. Thereby, the useful function of cytoprotection of the gastric mucosa is still available. Next, we come to erosive gastritis. Erosive gastritis usually presents with diffuse bleeding from multiple erosions in the gastric mucosa, which is clearly seen in this patient. See, multiple superficial erosions here with blood stains. This is more diffuse with a lot of blood stains in, and these are diffuse bleeding. Most bleeding stops spontaneously when the causative chemicals, especially NSAID or alcohol, are stopped. Progedes is used to confirm the lesion, and endoscopic treatment of bleeding is the treatment of choice. Rarely, these days, we need surgery to control the bleeding. The next type is known as gastric stress gastritis due to stress. This is a common sequelae of some form of serious illness or injury to the patient. In such conditions, there is reduced blood supply and relative ischemia to the gastric mucosa, which causes superficial ulcers to form, known as erosions. Although it is quite common, but it is usually not recognized unless it develops severe stress ulceration which results in bleeding. Prevention is a better method of treatment, and prevention of the stress bleeding from the stomach is effectively done by the use of H2 antagonists. Okay, H2 antagonists with or without barrier agents, cytoprotective agents to protect the gastric mucosa. There are two types of ulcers which is commonly seen: curling ulcer due to severe burns, and Cushing's ulcer due to severe head injury. Okay, the next condition we'll be talking about is a very important and common condition known as peptic ulcer. Okay, peptic ulcer is the loss of continuity of the epithelial surface that is surrounded by a medium of acid. The common sites are the first part of the duodenum, D1, and the lesser curve of the stomach. Other sites: stoma following gastric surgery, distal esophagus, Meckel's diverticulum where there is presence of ectopic gastric mucosa. Two important factors are involved in this development or production of peptic ulcer. Infection with H. pylori is has become a common infection these days that predisposes to peptic ulcer, and the use of NSAIDs, or both combined. Cigarette smoking predisposes to peptic ulceration and especially relapse. The important facts about peptic ulcer disease is the role of hydrochloric acid. This is very important. All ulcers can heal in the absence of acid. Okay. B. Very high acid levels, example in gastrinoma, will cause Zollinger-Ellison syndrome with multiple duodenal ulcers. Okay. So these are the two important role of hydrochloric acid in ulcer formation. Duodenal and pre-pyloric ulcers usually have high acid levels, whereas gastric ulcers may have normal or lower acid levels. Genetic factors and social stress are also important but minor factors in the creation of a peptic ulcer. And very often it is clinically not possible to differentiate gastric from duodenal ulcers. Now we come to the clinical features of peptic ulcer. What are the symptoms and signs? The main symptoms are classified into what we call dyspepsia, okay, which is characterized by pain, the most important symptom. And the pain is in the epigastric region, gnawing in nature, and may radiate to the back, and which is usually aggravated by sourish, spicy food, strong tea, coffee, and alcohol. At times it is relieved by taking food, and the pain is usually intermittent, rarely constant. The periodicity of the pain is also important. It's a chronic disease, so the periodicity of the pain is also important. Symptoms may disappear for weeks or months and then return again. Vomiting, nausea, belching, and bloating are other associated symptoms. Alteration of weight, usually weight loss, sometimes weight gain, may be associated factor. The signs of peptic ulcer is basically epigastric tenderness. Okay, there is no guarding. Okay, rarely there is guarding. If there is guarding, then you must think of perforated peptic ulcer. Pallor and sometimes due to bleeding, slow bleeding may cause pallor in the patient. What are the investigations that can be done for peptic ulcer. The primary investigation of choice is a gastroduodenoscopy, or OGDS in short. It is the investigation of choice, highly sensitive and specific. And all gastric ulcers must be subjected to multiple biopsies taken to exclude malignancies. The test that can be done during OGDS is the flow test to detect H. pylori. Okay. Other tests can be done before the scope, can be breath test or serological test. It is really important to check through carefully, especially the gastroesophageal junction, the pylorus for deformity, obstruction, narrowing, and also the first part of the duodenum. Barium meal, which used to be a very common main investigation some years back to diagnose peptic ulcer, is rarely required these days because of OGDS. Okay, this slide shows you pictures of the gastric ulcers. Okay, two pictures here. This ulcer here, benign gastric ulcer. Another picture here show a benign gastric ulcer. Okay, the etiology of gastric ulcer is H. pylori and NSAIDs plus smoking. Gastric ulcer is less common than duodenal ulcer. Male and female ratio is about the same, and usually older patients are affected with duodenal ulcers, and ulcers can be large compared to duodenal ulcers. Usually occur at the lesser curve, especially at the incisura angularis. Okay, this is a barium meal, showing you a large crater here. Okay, and this is a large gastric ulcer along the greater region. And these gastric ulcers can erode into the pancreas or into the posterior wall, and the splenic artery can be eroded and cause massive bleeding. Rarely erodes into the transverse colon. Sometimes in the body of the stomach, a large ulcer with fibrosis, okay, can cause an hourglass deformity of the stomach. Okay, although it's not common, but it's a classical deformity which is seen on barium meal. Okay, for your information, this is a hourglass that we usually use to time a timer as a timer. Diagnosis these days is quite straightforward, flexible endoscopy, and as it is a stomach cancer, chances of malignancy is possible, so you have to take multiple biopsies so as not to miss the gastric carcinoma. The next thing about duodenal ulcer, its etiology is the same as gastric ulcer: H. pylori, NSAIDs, and smoking. With widespread use of anti-secretory agents and H. pylori eradication has reduced the incidence of duodenal ulcers of late. Still, it is more common in men, and incidence is now older age group. Usually involves the first part of the duodenum, first part, and if it occurs in the pyloric region, the first part, between the first part and of the duodenum and the pylorus, it can cause stenosis of the pylorus and cause gastric outlet obstruction. The picture on the left here shows you a large ulcer here, crater. It's in the duodenal ulcer, which can also be seen in here in our barium meal. Duodenal ulcers usually tend to be multiple, more than one ulcer can be seen. Both posterior and anterior wall of the first part of the duodenum can be involved, and such ulcers are known as kissing ulcers here, anterior and posterior walls. The anterior ulcers tend to perforate and they erode through the mucosa, which has become a continent. The posterior duodenal ulcer tend to bleed as they erode into the gastroduodenal artery, which runs on its posterior surface. The important factor is duodenal ulcers are rarely malignant. In fact, duodenal ulcers in principle are always considered to be benign. The picture here shows you an anterior duodenal ulcer with a crater here, okay, on barium piece, and this is a kissing ulcer. Okay, now some discussion on Helicobacter pylori. Helicobacter pylori has become as a popular causative agent which has been identified in the 80s, for which the Warren and Marshall both received the Nobel Peace Prize for Medicine and Physiology in 2005. Originally known as Campylobacter pylori, it is usually spread by the fecal-oral spread, and most common infection of the stomach today. H. pylori produces urease, which hydrolyzes the urea to ammonia, which is an alkali which causes more gastric release. So gastric acid hypersecretion is produced in patients with Helicobacter infection. Detection is through the flow test, which is commercially available urease test kit, where some tissue from the stomach is taken and placed in the kit. The change of color will indicate whether the flow test is positive or negative. It can also be detected by the breath test. Urea can be tagged, and the breath test can detect the presence of tagged 13C and 14C urea. And it can also be detected by antibodies, serum IgG to the H. pylori test. H. pylori infection, or how does it cause ulceration? It leads to the disruption of the gastric mucous barrier, which I explained earlier, by enzymes and production of cytotoxins that incite inflammatory response by neutrophils, macrophages, and lymphocytes. And this causes type B gastritis, which can progress on to cause ulcers. The enteral mucosal biopsy will be able to show colonization with H. pylori, and this can be detected by the GIMSA stain. In the stomach, chronic atrophic gastritis from Helicobacter pylori infection may lead to generalized inflammation known as pen gastritis, and this can lead to gastric cancer. Normal duodenal mucosa cannot be infected with H. pylori. Duodenal mucosa response to excess acidity is to undergo gastric metaplasia. So when this gastric metaplasia takes place in the duodenum due to increased acid, the same inflammatory process of Helicobacter seen in the stomach now is observed in this duodenum, which leads to ulceration. The eradication therapy, eradication of H. pylori, is by means of a regime of clarithromycin, amoxicillin, and a proton pump inhibitor. okay, such as omeprazole. And normally it is given for 10 to 14 days, not 7 days. Last time we find 7 days, but now they find we give for 14 days. The eradication rate can go up to 90%. Okay, what are the treatments available for peptic ulcer? So the three forms. Non-pharmacological treatment is lifestyle modification, avoiding smoking and alcohol consumption, change of diet to avoid sourish or spicy food, avoid strong tea or coffee, avoid NSAIDs and other drugs like steroids, which are irritants and destroy the mucosal barrier of the stomach. The pharmacological treatment includes antacids for symptomatic relief, histamine receptors, H2 receptors antagonists, which reduce the production of acid in the stomach, in the parietal cell, proton pump inhibitors, PPI, okay, such as omeprazole, which cause total inhibition of hydrochloric acid in the stomach, and the eradication of H. pylori infection by the triple regime which I mentioned earlier. Lastly, surgical methods may also be used at times when necessary. The indications for surgery, which is becoming less and less these days, and nowadays only less than 20%, maybe even less than that, of patients require surgery for the control or treatment of peptic ulcers. Usually due to failure of medical treatment, the present regime of treatment for for peptic ulcer is very effective. As a result of that, surgery becomes less necessary. Complications of peptic ulcer usually treated surgically, such as perforation, obstruction, gastric outlet obstruction, bleeding from the duodenal ulcer, and malignancy in gastric ulcers is an indication for surgery. These are the general principles of treatment. Gastric ulcer, we do a Billrod 1 gastrectomy with gastroduodenostomy. Duodenal ulcer, you do a Billrod 2 gastrectomy with gastrojejunostomy. This is known as the Polias operation. Then there is vagotomy. There are 3 types: truncal vagotomy and drainage. Okay. The drainage procedure is normally a pyloroplasty or a gastrojejunostomy. Selective vagotomy and highly selective vagotomy, where we preserve the vagal trunks but divide the supply to the body and fundus of the stomach. The last one is your truncal vagotomy with enterectomy, so that to avoid doing a bypass procedure. Okay, these pictures here demonstrate or illustrate the various types of surgical procedure that are available. Billrod 1 is for gastric ulcer, where the ulcer is bearing part of the stomach is removed and a duodenal gastroduodenostomy done. Billrod 2 is a partial gastrectomy done, part where the ulcer is removed and a gastrojejunostomy is done. Okay, GJ bypass. Next operation that is available is truncal vagotomy, where the main vagal trunks, anterior and posterior trunks are divided, and once division of vagal trunks will cause abdominal or gastric stasis, and these patients will need a drainage procedure, and these are 2 types: pyloroplasty and gastrojejunostomy. And the other form of vagotomy is known as the highly selective vagotomy, where the main trunks are spared, but the branches of the vagus nerve that supply the body and the cardia of the stomach are transected by a longitudinal superficial incision. Okay, and this less chance of stasis, so the indication for the pyloroplasty or a drainage procedure is avoided in this type of operation. Okay, what are the sequelae complications of peptic ulcer surgery? There are a long list of them, which I will not go into today. The complications will be done in another lecture. Recurrent ulceration, okay, it's very important. Small stomach syndrome, where the patient feels early satiety after taking a small amount of food. Bilious vomiting, okay, due to stomach obstruction. Dumping syndrome, early and late dumping syndrome. Early dumping syndrome is due to hypovolemia, and late dumping syndrome is called hypoglycemia. Iron and B12 deficiency anemia, because part of the stomach has been removed. Gallstones after truncal vagostomy because of the bile stasis, and malignant change in the case of the gastric stump. Complications of peptic ulcer are very, very, very important, and this will be covered in another lecture because it's quite a long topic. So I shall just list out the list of complications that are commonly seen. Perforation of peptic ulcer, okay, this one. See a duodenal ulcer, the first part of the duodenum, there's a perforation, hole in the ulcer. Second is bleeding. See, this has eroded the gastroduodenal artery, and then there's a spurting of blood, which is a bleeding peptic ulcer. Stenosis, the pylorus, because of the ulcer, chronic ulceration and scarring, it narrows the pylorus and results in gastric outlet obstruction, or GOO, G-O-O. And the last major complication is a gastric ulcer becoming malignant transformation. Okay, this can be detected easily and diagnosed easily by a multiple gastric biopsy. Next, I go on to part 3 to talk about some malignant lesions of the stomach, in particular reference to adenocarcinoma. Carcinoma of the stomach. Carcinoma of the stomach, or cancer of the stomach, is not a very uncommon carcinoma. It affects Asians more. It is more common, geographically more common in Japan and some parts of Asia, especially China. The age group most susceptible to this cancer is the elderly patients, average age of 65 years. Men are more commonly affected than women. As for the causative or etiological factors, Helicobacter pylori infection associated with gastritis, gastric atrophy, and intestinal metaplasia has become the most very common predisposing factor for this condition. And in these cases of Helicobacter pylori causes, the carcinoma occurs at the body and distal stomach. Other risk factors are pernicious anemia, gastric polyps, previous peptic ulcer drainage procedures, example, Billroth-2 gastrectomy or vagotomy and drainage. What are the special peculiar risk factors for carcinoma of the stomach? Tobacco smoking and industrial dust ingestion, diet, pickled vegetables, salted fish, excessive dietary salt, smoked meat are considered to be high risk for the development of cancer stomach. Smoked meat, especially smoked salmon, is supposed to be a very important cause in Japan. Diet, fruits and vegetables rich in vitamin C give some degree of protective effect to developing cancer of the stomach. Now, the histopathology of gastric cancer. What are the types? What are the different histological types that you have? First, you have adenocarcinoma, which is the most common. 90 to 95% of all gastric cancers are adenocarcinoma. And this, according to the histological variety, it can be tubular, papillary, mucinous or signet ring cell, and undifferentiated lesions. Younger patients tend to have a more aggressive histological type of cancer. Second, lymphomas. Second most common gastric cancer after adenocarcinoma. The others will be gastrointestinal stromal tumor or GIST, which account for 2%, carcinoid tumor 1%, adenoacanthomas 1%, and squamous cell carcinoma 1%. As for advanced gastric cancer, the clinical features are much more direct. Early satiety, bloating, distension, and vomiting. This early satiety is a very significant symptom in these patients. So elderly patients coming with the bloating and early satiety always must try to arrange to do a scope for him. The tumor may bleed, and that causes iron deficiency anemia. It's another common symptom of anemia. Symptoms of anemia: pallor, breathlessness, and feeling tired. Epigastric mass and hepatomegaly, weight loss and pain at night. Features of gastric outlet obstruction such as dysphagia, epigastric fullness, vomiting, especially in pre-pyloric tumors, gastric outlet obstruction. Alkalosis is usually less pronounced or absent due to relative hypochlorhydria in the stomach due to diffuse gastritis, concomitant presence of diffuse gastritis in these patients. Late signs will include metastasis to Burkhouse node in the left supraclavicular fossa, which is known as the Troisier sign, and unexplained weight loss, pallor, and lethargy. In an elderly patient, always we must think of carcinoma of the stomach, and he must be investigated with the OGDS. Non-metastatic effects of malignancy. Sometimes patient can present with the paraneoplastic syndromes, thrombophlebitis, which is known as Trousseau syndrome, deep vein thrombosis due to the effect of tumor on thrombosis and hemostatic mechanisms. These are all rare but possible associated presenting symptoms in the minority of patients. In most countries, including Japan, carcinoma occur at the body and distal stomach, more commonly than proximal stomach. Proximal gastric cancer apparently not associated with H. pylori infection, in contrast with carcinoma of the body and distal stomach. What are the investigations that must be done in patients suspected to have gastric cancer? Most important and the most effective is endoscopy and biopsy. Previously, this endoscopy and biopsy has replaced the previously popular chest X-ray and double contrast barium meal X-ray. Second investigation, contrast enhanced computer tomography or CECT of the thorax, abdomen and pelvis. This is also very important for the staging of the disease. Endoluminal or endoscopic ultrasound and laparoscopic ultrasound are also done in most cases before operation in order to ensure there is no secondaries in the abdomen. In some patients, you may want to do a post-emission tomography, PET scan, and together with CT scan. Using fluorodeoxyglucose (FDG) to detect occult metastasis. Now we come to the classification of gastric cancer. Okay, the Lauren classification. According to this classification, there are two forms of gastric cancer. Okay, one is known as the intestinal gastric cancer, where there is a polypoid tumors or ulcerative lesion in the mucosa of the stomach, and these are probably areas. These tumors arise in areas of intestinal metaplasia. Then there is the next type, is the diffuse gastric cancer, which infiltrates deeply into the stomach with no obvious mass lesions. It spreads widely in the stomach wall at an early stage, and this is what we call Lionitis plastica. Okay, the next classification is the Japanese classification of early gastric cancer or EGC. Early gastric cancer is defined as cancer limited to the mucosa and submucosa with or without lymph node spread. Okay, so it's T1 and any N nodal status, any nodal status. Japanese classification is type 1, can be seen in this diagram here, is protruding type. Type 2 is superficial, involving the mucosa of the stomach. And the third one is the exacerbated or cavity type of thing, which involves the wall, the muscular layer of the stomach. Okay, on endoscopy, these are the pictures that you can see. This is the protruding type. You can see here protruding type. And number 2 here is the superficial type. Okay, you see superficial, more ulcerating. And the third type is your exacerbated type, where there are deep ulcers, penetrating to the wall of the muscular wall of the stomach. Then there is the advanced gastric cancer, the classical classification, and this is classified according to the Bowman classification. The cancer that infiltrating the muscularis layer is called advanced cancer. And according to Bowman's classification, there are 4 types. And the first type is the protruding type here. Can you see? Type 1. Type 2 is the ulcerative type here. Okay. Type 2 is the ulcerative type. Type 3 is ulcerative and infiltrating. Ulcerative and infiltrating. That is type 3 here. Okay. The superficial ulcer with deep infiltration into the wall. And type 4 is purely or infiltrative. Okay. Which is known as the Lionitis plastica. In fact, type 3 is the early form of Lionitis plastica, and type 4 is your advanced Lionitis plastica. And Lionitis plastica is commonly considered incurable. Next, we come to the Tnn classification. The T status represents the tumor size and penetration. It can be as tumor in situ, TIS, T1, T2, T3, and T4, as all shown in this picture here. T1, when it is involved the lining, the mucosa of the stomach. T2, when it's grown into the muscular wall, okay, the longitudinal muscle, the inner layer of the muscular wall. And T3, it is spread through the outer serosa, but it does not cause any infiltrated to any organs yet. And tumor, T4 is tumor spread to the other nearby organs. The end, end status is cancer has not spread to the lymph nodes is N1, N2, N3, and N1, N2, N3 are assured. Okay, less than 6 nodes, 7 to 15 nodes, and more than 15 nodes. And M0 and M1 are the classical no metastasis and metastasis. This is a clearer picture of the Tnn classification. We have a mucosa here, stage 1 or TIS. Submucosa, involve the submucosa here is stage 1 within the submucosa. Stage 2 has gone to the muscle layer, especially the inner longitudinal layer. And stage 3 has gone to the serosa, but it has not gone outside the serosa yet. And the stage 4, when it has penetrated the serosa into the neighboring organs. Now the spread of gastric cancer. The number of ways it spreads which are important for the spread of gastric cancer. Direct spread through the muscularis, through the serosa. Okay, to the wall of the stomach, into the serosa, and then to the adjacent organ. The adjacent organs involve commonly the pancreas, colon, and liver. These are the adjacent organs. Then you have the lymphatic spread, both by permeation into the lymphatics and embolization into the lymphatics. Then you have the hematogenous spread, usually after it spreads to the lymphatic nodes first and then to the hematogenously into the liver, lung, and bone. These are the common sites of hematogenous metastasis. Another important mechanism of spread for cancer stomach is known as the transperitoneal spread, where the tumor infiltrates the serosa into the peritoneal cavity and spreads along the lining of the peritoneal cavity into the whole abdomen. Classically, this is known as carcinomatosis peritonei and usually presents with ascites. It's an advanced condition. In case of cancer, the patients are usually very emaciated and they usually have cross ascites which can be detected by clinical methods. Some of the deposits will be deposited in the Bloomer rectal shelf, and these can be palpable on per rectal examination. The Bloomer rectal shelf is a rectovesicle or a rectouterine pouch in the patient. Then you have the Krukenberg tumors, which are gastric tumors spreading through the transperitoneal spread to the ovaries. And lastly is the Sister Joseph's nodule at the umbilicus, which is also due to transperitoneal spread to the umbilical region. Okay, these pictures, these are CT scan. These are the gross findings at surgery. Transperitoneal spread. You see multiple nodules scattered all over the peritoneal lining of the intestine. Okay, on CT scan, they can be seen as hyperdense nodules, tiny hyperdense nodules around the lining, in the lining of the peritoneum. Here and here, this is larger nodules which are seen in the peritoneum. And I told you, peritoneal metastasis to the Bloomer shelf. This is the Bloomer shelf that can be detected on digital examination. Okay, the deposits of cancer in this bladder, this is the rectum, so rectovesical space here, this pouch. Okay, this is known as the Bloomer shelf in males. This is a picture to show you the rectovesicle and the rectouterine pouch, where tumor metastases from the peritoneal spread in cancer of the stomach are deposited. Next, we come to the operability of gastric cancer. Okay, it's a very important factor to consider whether the patient, the cancer status is operable or not. So the assessment is very important, initial assessment using CT and PT scans PET scans, and preoperative laparoscopy. Okay, preoperative laparoscopy is the best way to diagnose transperitoneal spread into the abdomen. Once there is transperitoneal spread, the case is considered advanced and inoperable. So preoperative laparoscopy with biopsy of these lesions can be done, and it will give us an accurate diagnosis of the status of the cancer. Usually the cancer is considered incurable or inoperable in the following conditions: when there is hematogenous spread, especially to the liver, lungs, bones. Okay. Secondly, involvement of the distant peritoneum, okay, but through the distant transperitoneal spread, N4 nodal disease and disease beyond N4 node. Okay, this is quite advanced, and fixation to structures that cannot be removed. Okay, for example, the pancreas, the liver, all these are fixed, where the tumor gets fixed to the aorta, so cannot be removed. So this is considered incurable. If the patients are operable, then they should also have neoadjuvant chemotherapy. Then radical total gastrectomy in cancers that are operable. The aim is to remove the stomach and block, including tissues of the greater omentum and lesser omentum. The resection margins of the stomach must be clear of tumor. More than 5 centimeters margin is advised. The esophagus is divided and the whole stomach is removed. At times, the spleen, splenectomy, and distal pancreatectomy may have to be done in order to get curable resection. Once you've done a total gastrectomy, then you have to re-establish the continuity. Okay, and this is done by 2 ways. The main method of rejoining or establishing continuity is a esophagojejunostomy. Okay, this is a esophagus, this is a jejunum. So esophagojejunostomy. This can be done either side to side or end to side, whatever way is convenient, and also a Roux-en-Y anastomosis between the jejunal loops here, distal jejunal loop. Okay, so what the two procedures that are done is a esophagojejunostomy and a Roux-en-Y jejunostomy. The lymph nodes removal depends on the site of the primary tumor. Generally, it's a D1 gastrectomy where the first tier N1 nodes are removed. D2 gastrectomy is the second tier N2 lymph nodes are also removed. Subtotal gastrectomy is usually for distal tumors of the distal stomach. Okay, they are suitable for tumors very distal part of the stomach, where the fundus is preserved and the blood supply from the short gastric arteries. Okay, the fundus is preserved, and these are supplied by the short gastric arteries, which are preserved. This close the stomach from the lesser curvature. Anastomosis, great curvature of the jejunum, as in Billrod 2. Either do a Billrod 2 gastrojejunostomy or Roux-en-Y jejunal loop. Okay, Roux-en-Y anastomosis. This either do a Billrod 2 type of operation or Roux-en-Y jejunal anastomosis. Now we come to the palliative treatment for inoperable cases. Okay, there are quite a number of them. Carcinoma of stomach is famous for presenting late because of delayed diagnosis. Palliative surgery, gastrojejunostomy or Roux-en-Y anastomosis, gastrostomy sometimes when the tumor is causing blockage. So you can insert a tube into the stomach to decompress the stomach and also act as a feeding gastrostomy. Palliative chemotherapy, the drugs that are used is pirubimazine, cisplatinum, and 5-fluorouracil. Palliative radiotherapy, especially for painful, bony, or local metastasis which cannot be resected. These days, immunotherapy has become also important. Use of monoclonal antibodies. Okay, trastuzumab or Herceptin has become an important drug in immunotherapy because some of these cancer cells are HER2 positive and they respond to Herceptin treatment. Finally, we come to the prognosis of gastric cancer. Again, as like in all malignancies, it depends on the stage of diagnosis. The 5-year survival rate depends on the stage of diagnosis. Overall, it comes to about 70%. Okay, if you diagnose early and treat, you can get 70%. In stage 1, it can be as high as 90%. Stage 2, as high as 70%. Stage 3, around 50% or so. And stage 4 is low, less than 10%. Okay, so the degree, as I told you, the Tnn classification, the stage of the disease determines the 5-year survival rate. Next, I'll briefly go through a few important other tumors other than adenocarcinoma. First is known as the GIST, or gastrointestinal stromal tumors. Previously, it is known as used to be called leiomyoma and leiomyosarcoma. And these are tumors of mesenchymal origin associated with the oncogene mutation in tyrosine kinase c-KIT. It is sensitive, therefore, to tyrosine kinase antagonist, and imitanib is an important drug that is used to treat these cases. The male to female ratio is the same. The tumors, when the tumors are small, they are usually asymptomatic. And tumors more than 5 centimeters diameter have a malignant potential. They may ulcerate and bleed on rare occasions and also behave like the malignant adenocarcinoma, spread through the peritoneum and liver. The treatment is by veg resection for small tumors and gastrectomy for large tumors. Okay, this is a barium male. This is a CT scan. This is a CT scan of the abdomen showing you the tumor in the stomach. This looks like a benign tumor, well encapsulated. Next, we come to the primary gastric lymphoma, which is the second most common after adenocarcinoma. This is derived from the B cells, which arise from the mucosa-associated lymphoid tissue, or MALT, located in the wall of the stomach. Usually, it affects patients above 50 years of age. Pain, weight loss, and bleeding common presenting symptoms. At times can have acute hematemesis, perforation, or even obstruction. Endoscopy is the main line of treatment with diffuse thickening, mucosal thickening, and ulcer as the main features that you see in ultrasound, OGDS. Treatment is total radical gastrectomy, and for diffuse lymphoma with gastric involvement, chemotherapy is the main line of treatment. We come to the end of today's lecture on stomach and duodenum. In part 1, I tried to cover the anatomy, the physiology, the acid secretion and the investigations for gastric and duodenal lesions or diseases. In part 2, I went on to discuss the various benign diseases of the stomach, especially in relationship to gastritis, peptic ulcer, and H. pylori infection. I also touched briefly on the complications of peptic ulcer disease. In part 3, I talked about the malignant lesions of the stomach with particular reference to the adenocarcinoma of the stomach. I thank you for joining me for this lecture, and once again, thank you and see you again in another session.